before it's snared by organs and molecules designed to neutralize and expel foreign substances. This process starts in your digestive system. Say you swallow an ibuprofen tablet for a sore ankle. Within minutes, the tablet starts disintegrating in the acidic fluids of your stomach. The dissolved ibuprofen travels into the small intestine and then across the intestinal wall into a network of blood vessels. These blood vessels feed into a vein, which carries the blood and anything in it to the liver. The next step is to make it through the liver. As the blood and the drug molecules in it travel through liver blood vessels, enzymes attempt to react with the ibuprofen molecules to neutralize them. The damaged ibuprofen molecules, called metabolites, may no longer be effective as painkillers. At this stage, most of the ibuprofen makes it through the liver unscathed. It continues its journey out of the liver, through veins, into the body's circulatory system. Half an hour after you swallow the pill, some of the dose has already made it into the circulatory bloodstream. This blood loop travels through every limb and organ, including the heart, brain, kidneys, and back through the liver. When ibuprofen molecules encounter a location where the body's pain response is in full swing, they bind to specific target molecules that are a part of that reaction. Painkillers like ibuprofen block the production of compounds that help the body transmit pain signals. As more drug molecules accumulate, the pain-canceling effect increases, reaching a maximum within about 1 or 2 hours. Then the body starts efficiently eliminating ibuprofen, with the blood dose decreasing by half every 2 hours on average. When the ibuprofen molecules detach from their targets, the systemic bloodstream carries them away again. Back in the liver, another small fraction of the total amount of the drug gets transformed into metabolites, which are eventually filtered out by the kidneys in the urine. The loop from liver to body to kidneys continues at a rate of about 1 blood cycle per minute, with a little more of the drug neutralized and filtered out in each cycle. These basic steps are the same for any drug that you take orally, but the speed of the process and the amount of medicine that makes it into your bloodstream varies based on drug, person, and how it gets into the body. The dosing instructions on medicine labels can help, but they're averages based on a sample population that doesn't represent every consumer. And getting the dose right is important. If it's too low, the medicine won't do its job. If it's too high, the drug and its metabolites can be toxic. That's true of any drug. One of the hardest groups of patients to get the right dosage for are children. That's because how they process medicine changes quickly, as do their bodies. For instance, the level of liver enzymes that neutralize medication highly fluctuates during infancy and childhood. And that's just one of many complicating factors. Genetics, age, diet, disease, and even pregnancy influence the body's efficiency of processing medicine. Someday, routine DNA tests may be able to dial in the precise dose of medicine personalized to your liver efficiency and other factors. But in the meantime, your best bet is reading the label or consulting your doctor or pharmacist and taking the recommended amounts with the recommended timing.
Okay. All right. So it kind of gives us a better explanation of biopharmaceutics. And when we take medications, how do they know what to do when we take them? So we take a medication for a headache. How does that medication know to stop the headache? So also included with biopharmaceutics is we just talked, the video showed taking a solid dosage form. So we're going to talk about some of the different dosage forms. So with tablets, they consist of active ingredients, fillers and disintegrators, dyes, flavoring agents, and outside coatings. You have capsules. They consist of either a hard or soft gelatin shell that encloses the active ingredient. We have troches. These are forms of lozenges or pastilles. Suppositories or inserts. These are going to be solid dosage forms, generally designed for vaginal or rectal delivery. And then a medication in solid form will generally require more time to enter the body than the same medication in liquid form. So with our liquid dosage forms, we have solutions, which are homogeneous mixtures of solid, liquid, or gas dissolved in another liquid. Emulsions, which consist of two immiscible liquids. One liquid appears as globules uniformly dispersed throughout the other liquid. And then you have suspension, which is a solid medication dispersed throughout a liquid medium. So next we're gonna move on to pharmacokinetics. So pharmacokinetics is defined as the study of the way the body processes a drug. This includes how drugs are absorbed, reach their site of action, are metabolized, and then eliminated from the body. And the video we watched touched on at the very end, touched on this last point, the things that affect the response a person has to the drug. It can vary according to age, physical condition, sex, weight, and immune status. So with pharmacokinetics, there are four parts to that process. You have absorption, which this is the movement of the drug from the site of administration into the systemic circulation in order to provide a desired effect. You have distribution. This is the means by which a drug travels from the bloodstream to the target tissue and site of action. You have metabolism. This is the process by which the body transforms the drug into an inactive form that can be excreted from the body. And then you have excretion. This is the elimination of the drug from the body after it has been metabolized. So all are processes of pharmacokinetics that we just went over, except. So you have A, absorption, B, digestion, C, excretion, and D, distribution. Which one of those are not a part of the pharmacokinetic process? You can answer in the chat. Okay. So let's look back at that slide. We have absorption, distribution, metabolism, and excretion. So the correct answer is B. Digestion is not a part of that process. So with pharmacokinetics, our medications are metabolized in our liver, and then they're transported by our bloodstream to the kidneys for excretion. If the kidney function is impaired or if the patient is dehydrated, drugs can be retained in the body and a toxic or poisonous effect can occur. When toxic effects occur, they're more likely to happen in patients that have insufficient fluid intake. So we're gonna watch a quick video about that process. Cooperate. Nah.
Picture this. You're sitting at home alone watching YouTube videos, wondering why you can't find the motivation to do the things you.
Medication absorption is the movement of a drug from its site of administration into the blood. Oral drugs enter the stomach, where they either dissolve and pass through the cell membranes of epithelial cells lining the stomach, or travel undissolved through the stomach to the small intestine, which is the most common site of absorption. Here, drugs dissolve and pass through the intestinal wall. Oral drugs then travel through the portal venous system to the liver, where they undergo the first pass effect. During this process, the liver metabolizes some of the drug, either inactivating it or excreting it into bile for elimination from the body. The remaining amount of active drug leaves the liver and reaches general circulation and target organs. If a drug is administered via intravenous injection, it passes directly into the bloodstream, thus bypassing absorption in the GI tract. If administered through intramuscular or subcutaneous injection, the drug enters either muscle or subcutaneous tissue, where it passes through gaps between cells into capillary walls, and then into general circulation or target organs, also bypassing absorption in the GI tract. Bioavailability is the net amount of a dose of a drug that is actually absorbed into the bloodstream. The bioavailability of oral drugs is less than 100% because of the first pass effect of the liver. In contrast, the bioavailability of IV drugs is 100% because they are not exposed to the first pass effect of the liver. Different drug formulations alter bioavailability because they are not absorbed at the same rate or to the same extent. For example, tablets dissolve at varying rates. Enteric-coated drugs dissolve in the small intestine, not the stomach. Because gastric emptying time differs between individuals, absorption times also vary. Sustained release formulas contain tiny spheres that dissolve at different rates, resulting in a steady drug release throughout the day, but also resulting in variable absorption. Some factors affecting drug absorption are the rate of dissolution. Drugs that dissolve faster are absorbed faster. Surface area. Since the lining of the small intestine has more surface area than the lining of the stomach, most drugs are absorbed faster in the small intestine. Blood flow. The greater the concentration gradient between the drug-filled stomach and the rapidly flowing drug-free blood, the faster the absorption. Lipid solubility. Highly lipid-soluble drugs pass through the phospholipids in the cell membrane more easily than drugs of low lipid solubility. And pH partitioning. Absorption is faster when the difference between the pH at the site of administration and the pH of the plasma attracts more drug molecules to ionize in the plasma.
Okay. Hold on. Let's see. Let me switch back over. All right. So that kind of gave us a little bit more detail on those different stages of pharmacokinetics, and how we take certain medications and how they kind of bypass um certain areas to have a greater effect or effect that effect that happens faster. So like taking an oral oral medication, it has to go through that first pass, then go to the liver versus intramuscular, or if we do an IV injection, that's going to get to the place it needs to go a little bit faster. So with pharmacokinetics, we talked about the drugs being metabolized, how they're excreted, the different ways they can be excreted. So with that, the drugs are excreted by the way of all except A, kidneys, B, intestines, C, liver, D, breast milk. You can go ahead and answer in the chat. Okay, so let's go back to the previous slide. So medications are metabolized in our liver, and they're one of the ways they can be excreted is by the kidney. So our answer choices for the ways drugs can be excreted were all the ways except. So we know for sure kidneys, kidneys is in fact a way the drugs can be excreted. We know C, liver is not a way that it can be excreted because we just saw that it's metabolized in the liver. The video we watched just touched on excretion happened through the intestines. So correct answer is going to be C, because drugs can be excreted through kidneys, through intestines, and through breast milk. So most drugs are metabolized through the A, lungs, B, kidneys, C, liver, D, heart. You can go ahead and answer in the chat. Most drugs are metabolized through which one of these? Okay. Correct answer is C, the liver. So just to kind of recap, medications are metabolized in the liver, and then they are excreted in the kidney. So medications are metabolized in the liver. They're transported by the bloodstream to the kidneys for excretion. So excretion happens, or how our body gets rid of those drugs happens. One way it can happen is through the kidneys. Okay. Next topic we're going to talk about is pharmacodynamics. So this is defined as the study of the effects of drugs on the normal physiological function of a body. So you have an agonist. An agonist is a drug that produces such a specific action and promotes the desired effect or result. An antagonist is a drug that attaches itself to the receptor, preventing the agonist from acting. So with being in imaging, we are familiar, or we need to be familiar with certain drug classifications, but we don't have to have like this broad knowledge that maybe a nurse or a doctor would have to have. It is good for us to be familiar with certain types of medications like blood thinners if you work in the interventional or any type of procedure areas, to know some drugs that are familiar blood thinner drugs, or that's going to be our anticoagulant drugs. Be familiar with diabetic medications, because that's one thing that we have to verify before we give patients contrast. So that's going to be your endocrine drug classifications. Also some different high blood pressure medications, to kind of know what what type of medications they're on, because that kind of gives us a snapshot of what our patient is going through. So very important to kind of know these classifications. You don't really have to always know specific drugs, but there are some common ones that we should be familiar with. And then also knowing what these drugs do. So if I take an anticoagulant drug, what does that drug do? If I take an antiplatelet drug, what does that drug do? If I take an antihistamine, what does that drug do? So being familiar with what these drug classifications do. So medicines are identified by their chemical name. That defines their composition, their generic name that identifies the substance, and the proprietary or trade name given by the manufacturer. So radiographers should be familiar with both the generic and the trade names commonly used for medication. Anytime we administer medications or anytime us as patients take medications, a few things that can happen. We take the medication and the intended effect happens. We have a headache, the medication stops our headache. But sometimes adverse things can happen. So one of those adverse effects or adverse things that may happen could be a side effect. So a side effect may be a predictable pharmacology action on the body system other than the action intended. So you may take a medication and it may cause you to be nauseous. But we know that from taking the medications, that's one of the warnings that it says that it may happen. So that's going to be considered a side effect. Adverse effect is going to be an unwanted effect. So we take that medication and something that is not supposed to happen happens. Toxicity. If we take too much of the medication, this can cause have a toxic effect. So the higher the dose, the greater the toxic effect. And then we can have an allergic reaction to the medication. So allergic reaction is going to be an immune mediated response by the body against the drug. So you take the drug, it goes in your system, and your body is like, wait, this is unfamiliar, and it tries to fight it off. So you have an allergic reaction to it. So treatment for allergic reactions. Anytime we administer contrast to our patients, or anytime a patient takes a medication that they've never taken before, or even if a patient has had contrast before, they can still have an allergic reaction. So we have a patient, and they've had contrast before, and they've had an allergic reaction. It should be noted in their chart. And then we should talk to the patient and ask them, do they have any allergies? And if they do have allergies, we're gonna treat them. So we're gonna pre-medicate them before we give them contrast again. So the types of medications that we treat with are gonna be antihistamines. So one common one is diphenhydramine hydrochloride. That's Benadryl. So we're gonna pre-treat our patients with Benadryl and then also with epinephrine or adrenaline. We also use corticosteroids. We usually use the Benadryl and the steroids together as a pre-medication. Sometimes we give epinephrine, but usually epinephrine is given if a patient has a reaction, and a patient is starting to have a severe reaction. We'll administer epinephrine. So what are some types of medications you may find in the radiology department? A, epinephrine, B, lidocaine, C, Benadryl, D, all of the above. You can answer in the chat. right, let's see. So correct answer is going to be D. Yes, we have all of these in our department. We keep the Benadryl, just in case a patient has a reaction. It can be used to pre-medicate. It also can be used to treat a reaction. We use the epinephrine if a patient is starting to have a severe allergic reaction. We use the lidocaine because in some of our areas, in our general area, even in CT and interventional, we do procedures. So lidocaine is used when we do those procedures. So all of the above is correct answer. So with us administering medications or radiographers administering medication, there are a couple things we should know. We kind of just talked about this. Should know the name of some commonly prescribed drugs. So some name of some common diabetes medications, some names of common high blood pressure medications, blood thinner medications. We should kind of be familiar with those. Administration routes of those common drugs. We really need to know the administration route of our contrasts. Some contrasts can be given IV and orally. Some contrasts can only be given orally. We need to know that. Standard dosage of most commonly administered drugs. So how much does the patient usually get if we have to give them that medication? And then signs of medication side effects, especially if a patient is having an allergic reaction. So with us being more involved with medication given during our procedures, of course, like I just talked about, we administer contrast agents that can be ingested or injected. We do use anesthetic agents like the lidocaine, which are injected before the insertion of a needle into the spinal canal or joint space, to kind of cause insensibility to the pain. So kind of deaden the area. So when we inject that needle, the patient won't feel pain or feel as much pain as they would without it. And then with MRI, our patients do tend to have anxiety or, so they take anxiety or sedation medications. Usually what happens with that is that a patient is ordered an MRI. Usually they let their physician know, hey, I get, I can't really lay still. I need something to calm my nerves. Usually what happens is their primary care or whoever ordered the test will give them a prescription for that anti-anxiety medication. They bring it with them and they'll take the medication before they start the MRI. Sedation usually happens if a patient the MRI is needed. It's very important, and the patient just like, hey, I just can't do this. I can't lay still. I can't, go into that tube. I'm too claustrophobic. It's not gonna happen. So they will sedate the patient. If you have to sedate the patient, that's a little bit more complicated. You need a nurse. Sometimes you need to include anesthesia in that. So it takes a little bit more coordination if we have to actually sedate a patient. But usually anxiety medication, sedation agents, that's going to have other people kind of come in and make sure that the patient is given that. We typically don't give that in our departments. Now, if your department or the department has a nurse and a doctor, they will or they can prescribe anti-anxiety medication, but typically that medication is the patient brings that medication with them to take before they start their MRI. So anytime medication is given, so if it's lidocaine, if it's epinephrine, if it's contrast, we have to chart that medication. If the nurse that we're working with, if the nurse gives medication, they're gonna chart it. So they're gonna chart in their in their notes what they gave. If we if we administer contrast, then we need to chart what we gave. So what you need to chart when you give medication, you need to make sure you have the name of the drug, the dose of the drug, how the dose was given, so the route the drug was administered, the date that it was administered, the time that it was administered, and generally the injection site. So was it given through a 22 gauge in the right AC? Was it given by an 18 gauge in the wrist? So we want to make sure we note the injection site as well. So anytime we give patients medication, we have to be mindful of the rights that go along with it. Now, we've discussed patients' rights like in the very beginning. So we know patient has a right to respectful care. We know the patient has a right to be informed about what's going on. We know the patient has a right to their medical records and confidentiality. But when we're administering medication, there are rights that the patient are entitled to and rights that we should know. So those include the right dose of the right medication to the right route. To the right dose of the right medication to the right patient at the right time by the right route with the right documentation. So anytime we administer medication, contrast, oral or IV to our patients, we need to follow these 6 rights. So we want to verify and identify our patient, make sure that we have the correct patient, make sure we have the right dose of medication, make sure we have the correct medication. Make sure we're giving the medication at the correct time, make sure we're giving it by the correct route, and then make sure we're documenting that we gave the medication. So, quick question, quick quiz. Just to recap, the 6 rights of medication administration include A, the right dose of the right medication to the right patient, B, the right patient with informed consent and verbal orders given, C, the right order with the right IV access and assigned DNR, or D, the right dose with standing orders and with informed consent. All right. So correct answer is going to be A. We want to make sure we have the right dose of the right medication to the right patient. So when we give medications, there are several ways we can give the patient medication. We talked about making sure that we know how a drug can be administered. So we need to know the ways that a drug can be given. But we also kind of need to be familiar with the different types of ways a drug can be given. So enteral route, this applies to medication administered directly into the gastrointestinal tract via oral or rectal sites or via a nasogastric tube. Oral route is when it dissolves in the stomach, and then we take a pill or take medication, it dissolves in the stomach and then passes into the small intestines where the majority of the administration takes place. So we take something by mouth, that's what happens. Rectal administration, we usually do rectal administration when the stomach has been traumatized or is non-retentive, or when a medicine has an objectionable taste or odor, or when it can be changed by the digestive enzymes. Inhalation or medication inhalation. This is when liquid medications are vaporized, administered by inhaler or nebulizer, or inhaled by the patient. So like a breathing treatment, or people with asthma, like an inhaler. Topical applications of medicine to the surface of the skin, also known as transdermal. we have sublingual. These drugs are placed under the tongue. So they're one drug that's considered sublingual is nitroglycerin. If a patient, they may be on nitroglycerin, they pop it, put it under their tongue, and it dissolves that way. Buccal, this is holding the drug between the gum and the cheek. And example of this, just went to the dentist the other day. Had to have a cavity filled, and they put some little medicine, numbing medicine on the Q-tip, and they put it at the top of my gum, and I had to hold it there. So that's gonna be considered what buccal is when you do things like that. That's the only way I think that's the only way I've ever gotten the example I can think of buccal, but they also injected some deadening medicine. So they basically put that there to kind of numb the gum, and then they injected me with something else to kind of numb it up. So that was real fun. Then parenteral. These are when medications are injected directly into the body and bypass the gastrointestinal tract. So this is when we do intradermal, subcutaneous, or intramuscular. So IV administration is also the parenteral route. And this is going to be the route that offers the most immediate effect. So by using this route, medications are injected directly into the body, bypass the gastrointestinal tract. This type of administration is classified according to the type of vessel in which the injection is made. So IV injections are the most common type of intravascular administration. So in the imaging department, the IV line is usually placed only for the duration of the procedure, and then used, and we usually use the antecubital veins when we inject or when we start IVs for our procedures. Now, normally with nurses, they're taught to start from the lowest point up. So they usually will use the hand as a first point to start IVs. But with us, that antecubital section is going to be the more common place that we start IVs if we have to start IVs for our contrast injections. So when we start IVs, the venipuncture process, we have to choose what type of needle we're going to use. If we're dealing with contrast, we're going to choose a specific size needle because you only have about 3 sizes, or usually have 3 sizes of needles that you can use. You can't use anything smaller than a 22 gauge needle to power inject IV contrast. So when we hear 18 gauge or 20 gauge or 22 gauge, what that means is the gauge, that number indicates the diameter of the bore, and the gauge increases as the diameter of the bore decreases. So a 18 gauge needle has a larger bore than a 22 gauge needle. So your 18 gauge needle, you would think it would be opposite, but your 18 gauge needle is going to be your bigger bore needle. So it's going to be the larger needle, as far as it's going to have the larger opening out of the 3 needles. And the 18 gauge needle is going to deliver a given volume of fluid more rapidly. But then a 22 gauge needle, we usually use those for people who have small veins, because using the 18 or 20, we may basically bust their vein, or it may not go into the vein, or we end up extravasating trying to start the IV. So usually people with smaller veins, we use a 22 gauge needle. It makes a smaller hole, and is less likely to cause a lot of bleeding when you take or remove that needle from the skin. So what is an advantage of IV administration medication? So A, immediate availability of the medication. B, best route for conscious patients. C, safest administration route. D, easiest administration route. So you think it's A, B, C, or D? Okay. So correct answer is going to be A, immediate availability of the medication. So anytime we start an IV and we're going to inject saline contrast, there is a chance that an extravasation or infiltration can happen. So you'll hear those terms kind of interchanged. People say extravasation, they'll say infiltration. So there is a difference between the two. So extravasation is when fluid leaks outside the vessel, and an infiltration indicates that it has diffused into the surrounding tissue. This can be painful and dangerous. You'll hear patients complain of discomfort, and you may observe swelling at the site. So if you have a full-blown infiltration, you will see swelling around the site. So what you should do is apply a cold pack to the affected area. If you don't have those kind of cold packs where you can kind of squeeze and it becomes cold, you can get a towel and put some ice cubes in it, wrap that, put it on the site, or you can put some ice in a plastic bag and put that on the site as well. This helps alleviate pain. It will also cause constriction of the blood vessels in the area and help to keep the infiltrate localized. Now, for test taking purposes, you need to know that a cold pack is what is recommended. But in real world, we use either a cold pack or we use a warm pack. We tend to use a warm pack when we do this. So we'll get a kind of towel, we'll get the same type of pack that you can kind of squeeze and it becomes hot. What we'll do is kind of get a towel, place that over the spot, and then put that warm pack over there. Both can alleviate pain. The warm pack tends to help that contrast dissolve under the skin a little bit better than the cold pack. But like I said, for test taking purposes, you need to know that a cold pack is what what is preferred. But just know if you ever go out into the clinical area or when you get out into working into departments, people have different practices. So if you see a hot pack, don't, know that you can use either or. But like I said, for test taking purposes, you need to know it's a cold pack. Once it happens, you need to get a radiologist and or nurse, have them come take a look at the site, let them know what happened, give them approximate amount of what has administered, what it infiltrated or extravasated. Then they usually will kind of assess the site and then give the patient any follow-up instructions on what needs to be done. One thing you also need to do is you also need to document the extravasation. So if you were giving the patient whatever amount, if the full amount infiltrated, you need to document it. If approximate amount infiltrated, you need to document. You always want to document that it happened. Number one, document the approximate amount and where it happened. And then you also want to document the person that you had to evaluate the patient and note that follow-up instructions were given. You always want to document those 4 things. So anytime we start an IV for venipuncture or we're dealing with an IV site, taking the IV out, like a nurse may have started it for us, but then we're going to take it out. We need to always practice standard precautions. So we want to always make sure we wear gloves. We want to dispose of any syringes and needles directly into a puncture-proof container without recapping. If we're starting IVs, we want to try to use safety design needles and needleless devices whenever possible. If we're starting an IV, we want to make sure we follow established rules of aseptic technique. And if we're taking the IV out, we want to make sure we follow those rules as well. If we are drawing up a medication to administer, we want to make sure we read the label 3 times before drawing up the medication, after drawing it up, and before it is administered. So a lot of times, if you work in a CT department, you may use different concentrations of contrast. So you may use Omnipaque, but you may use Omnipaque 300, and then you may use Omnipaque 350 for different exams. So just know that what you're drawing up, make sure that you're drawing up the correct contrast and the correct amount for that specific patient in the study. If you're drawing the contrast up before a procedure, or you're working with a radiologist and you're kind of helping them get their sterile fill together and the medications they're going to use, you always want to label your syringe with the medication name and the strength. A lot of times when you work with doctors nowadays, they just want you to have the medication out for them to see instead of drawing it up beforehand. They like to kind of draw it up when they're in the procedure. Now, some doctors who are old school, they may want you to go ahead and draw up everything and make sure it's labeled. But really, to err on the side of caution, you should wait till the doctor can visibly look at what it is, and you and the doctor can confirm what's being drawn up. Just quick story. In the intervention department I work in, we had a doctor who had a tech, and the tech would the doctor like for the tech to draw up the medications before, and the doctor typically use a different size syringe for his localization or his numbing agent, and use a different size syringe for the steroid injection, whatever he's using. So tech draws up both of them are clear, both of them in the same size syringe. So what happens? Doctor, looks at what it is. He pulls, both of them are clear. He trusts the tech. Hey, you drew up the lidocaine or the numbing agent in this syringe. And then I drew it up, and is that correct? Yes, sir. Drew that one up and that one, drew that one up and that one. So what ended up happening is, instead of the doctor injecting the contrast or the steroid injection into the joint space, and in this case they were doing lumbar injection, the doctor injected the lidocaine into the joint space. So caused a big issue. So now our process is to not draw the medications up prior to the procedure. We have everything laid out. The radiologist will come in. The radiologist verifies the medication and the expiration date. We look at the medication and the expiration date to make sure that he is using exactly what he needs to use at